I'm Hakim, and will be the first part of presentation about. Okay, before that, so the table of content is we have etiology and pathophysiology. Second was history. Third, physical examination. Fourth, investigation, and fifth is management. Okay, so right. So here's the first one. The
Siapa nama presenter tadi? Siapa nama
Saya
presenter
Hakim
tadi?
Al Hakim.
Nama awak apa?
Al Hakim.
Hakim. Okay.
Okay, so
Al
here
Hakim. Okay.
is acute abdomen. So here are the definition, which it was as the word it says is acute, meaning that it's acute onset and referring to the abdomen, which means the abdominal pain. And this abdominal pain can varying causes, such as we have obstruction, inflammation, and perforation, and so on. Okay, so if it's not treated, and it will be, of course, serious and potentially life-threatening. Okay, next, Ibrahim. Okay, so here are the 9 regions of the abdomen, which we can have an image on if the patient presenting to you saying that there was pain at certain region. Thus, this diagram can show the relation organ on that side. Okay, okay, next, Ibrahim. Okay, so here are the etiology of the abdominal pain. Of course, the first one is obstruction. So next is infarction, is lack of blood supply or tissue perfusion in the certain parts of the abdomen. And next is the perforation. Okay, and next is inflammation, intra-abdominal and peritoneal hemorrhage, and extra-abdominal and medical causes. So we can go one by one. Okay, so here the first one is obstruction. So obstruction, of course, it can occur along the gastrointestinal tract and leads to dilatation of the proximal plug and disrupts the peristalsis. And the presentation, of course, depends on the level of obstruction. It can be stomach, or proximal, or distal, small or large bowel. And it can be complete or partial, which patient mostly present with the cardinal symptoms of obstruction. First is pain, vomiting, absolute constipation, and distension. Okay, so intestinal obstruction has a cause of the most common causes is, of course, adhesion, whereby a patient has a previous history of abdominal surgery. Okay, and the second one can be hernia, and the last one, of course, colon cancer. Okay, all right. So next one. So here are the functional cause, which there's a temporary interruption of peristalsis and the pseudo obstruction of the colon, which is adenemic disorder. Where adenemic disorder is uh, there's a what we call functioning of the abdomen affecting by the uh, motor paralysis of the digestive tract, which it does not have any blockage along the gastrointestinal tract. Yet there's symptoms of obstruction. Okay. So next way. Okay, so here are the etiology that can be cause obstruction. It was in based on the belly and duct. It was divided. Essential surgery. It was divided into three. It can be either within the lumen, within the wall, or outside the wall. Okay. All right. So next way. Okay, so here are the common causes of obstruction by age. Of course, you can see in the young adult or adult and elderly, there's a hernia, adhesion, and carcinoma. Okay, next. Okay, next one is infarction of the viscous, where there's the blood supply of an organ is obstructed, and then there's causing.
Hakim kat kamera boleh, Hakim?
Okay. Yeah. So, all right. Okay. So that's the infection of the certain organ or certain parts of the uh, gastrointestinal tract. We can lead to abdominal pain. So infection of viscous, which most common, the most prone site is ischemic colitis, which at the splenic fracture of the large colon and the rectosigmoid junction, where it was a distal organ, and there's what we call watershed area, where we call the blood supplies ends ends at that part of the colon. Okay. Next one. Okay, so
So
here.
watershed area kat mana?
Huh?
Contoh ni watershed area.
Contoh watershed area dekat is splenic splenic fracture. Yes. Okay, and then next is another one is rectosigmoid junction.
Itu Simot Junction. Good. Dari nama dia kan Sudex dengan apa dia kata.
Sudex and ingat dulu.
Pada dalam textbook. So dia receive dua blood supply. Dia tak ada obvious blood supply. Dia receive dua blood supply. Splenic fracture kan, dia intertwine between SMA dengan IMA punya branch. So dia dapat macam tu je. Instead of dapat macam ni, dia dapat macam tu je. So area ni kalau you buat potong, senang compromise lah. Kalau dapat hypotension ke, patient hypotension, shock ke, so area tu akan senang. Underperfused dan mati lah.
Yes. So the splenic fracture we call it Griffith point. Okay, so here next is intra-abdominal. Okay, here see the organ that can prone to infarction. Okay, so next is their mechanism. Alright, so next over here. Okay, next is perforation of viscous. Okay, any hollow organ can cause perforation. Of course, the most common one was stomach. Okay, next is duodenum, sigmoid colon, and appendix. So the condition that's likely to cause perforation is peptic ulceration, which can later become perforated peptic ulcer. Okay, acute diverticulitis, the formation of the diverticula in the colon, and of course appendicitis, which later can have ruptured appendicitis, and the patient can develop sepsis, and it can be life-threatening. Okay.
Why boleh dapat gangrenous appendicitis?
Why you can have gangrenous appendicitis is
where the gangrene? Senang dapat gangrene. What is gangrene?
Function of the organ.
Patuh. Ya ke? Patuh. Apa lagi boleh gangrene? Bawel lah kan. Yang common. Macam appendix tak?
Feet.
Dalam abdomen lah. Kaki.
Ada abdomen. Sorry.
Team B patient. Siapa team B? Common ni. Gallbladder lah.
Gallbladder.
So kenapa dia senang dapat gangrene? Gallbladder appendix senang dapat gangrene.
Distal end organ.
Distal end organ? Maksudnya kaki pun distal end ada ujung kali. Dia distal end artery. The end artery. Dia bukannya datang pada banyak cabang. Senang tak perut dapat gangrene?
Less likely.
Why?
Because it receive it's not an artery because there's because stomach is supplied by at the lesser curvature and greater curvature of the stomach, and so there's not end arteries.
So dia punya supply banyak. Multiple artery lah kan. Short gastric semua kan. Epiploic. So that's why it's difficult for stomach to get gangrene, but not for gallbladder and appendix because it serve as an artery. Appendicular artery, cystic artery is an end artery. END, end, ujung. So any inflammation cause edema, they block off the compress and then they become ischemic and then become gangrene. So what is gangrene? Soalan ni Hakim kena jawab masa present. So that your friend understand.
As gangrene, the
It's an irreversible tissue loss. The irreversible, they cannot reverse dah gangrene. Dia cannot reverse. So that's why dia kalau perforated gangrenous gallbladder, buang je gallbladder kan. The irreversible tissue loss, dia dah mati dah. Whatever you try to salvage, it cannot reverse dah. Okay.
Yes, sir.
Okay, proceed.
Okay, next, Ibrahim. Next is the inflammation of the viscous, which we call known as peritonitis. So, of course, the clinical features of peritonitis is tenderness and guarding, rebound tenderness, and localized pain during distal palpation. And for example, perforated acute appendicitis, and there's abscess bowel wall, tachycardia, and pyrexia. So on physical examination,
apa yang tak betul dalam susunan awak nak cerita kat kawan awak ni?
susunan
Picture tu memang ada, tapi you susun betul-betul. Clinically you from general dia macam mana? Septic ke tak, pyrexia ke tak, tachycardia. That one should come first kan?
yes.
Lepas tu bila kat abdomen, apa you akan tengok? Distension ke? Isn't it? You nampak dulu kan? Presence of bowel loop ke? Baru you start touching. When you start touch, baru you nak tengok demam ke tak. They just how you present ni, how you do normal. Kita present, buat presentation ni macam you present case. Takkan you terus bagi blood, sibuk patah balik kan. Macam tu kan. Itu dah demo. Boleh?
Yes.
Okay, proceed. Next slide. Okay dah.
Next. Okay, so here are the causes of another etiology, which is intra-abdominal or retroperitoneal hemorrhage. And of course, the most common condition which can hemorrhage is a ruptured aortic aneurysm, ruptured spleen, and ruptured ectopic pregnancy. And which later, if it has been ruptured and exposed to the abdomen, which will later have the patient may have developed peritonitis. So here are the source and the other causes of hemorrhage in the intra-abdominal. Okay, next one. So the last one was extra-abdominal and medical causes, which can have abdominal pain. And of course, myocardial infarction can be one of if the patient presented to you with epigastric pain. And of course, that was the most common one. Okay. Okay, next one. Okay, so that's all from me for etiology and pathophysiology of the abdomen.
Okay, so next part is the history taking, which will be presented by me, Sufiana. So the approach to acute abdomen. So the hallmark of acute abdomen is the sudden onset of severe abdominal pain. So how to approach patient with acute abdominal pain? So for the
bergema. Bunyi apa? Kipas ke apa? Okay, aku cakap.
hello.
Okay, ada bergema tak yang lain?
Yes, ada.
Macam ada background sound yang kuat. Cuba cakap balik.
Bergema lagi ke?
Okay.
Okay, sorry. Okay, so for the hallmark of acute abdomen is the sudden onset of abdominal pain. So how to approach patient with acute abdomen is first we need to ask the pain using the Socrates, ask the risk factors and also other important history such as past medical history and also drug history, family history and also past surgical history. So mind you, the life-threatening condition of the acute abdomen such as ruptured aneurysm, mesenteric ischemic, perforated viscous myocardial infarction and also intestinal obstruction, so that we can detect early and also do early intervention. So next slide. Okay, so for the site, for the first component of the Socrates is the site or location of the pain. So the location of the abdominal pain helps narrow the differential diagnosis as different pain syndromes typically have different characteristic location. So so abdominal has 9 regions. This has been presented by Hakim. So if the pain if that is caused by liver or biliary, it will located at right upper conjunctive pain, and also if the pain at the epigastric, it could be esophagitis, peptic ulcer, pancreatic ulcer, and pancreatitis. You can read the slide. Next slide. Okay, so next is the onset of the pain. So either within seconds, within minutes, and within hour. So pain that comes suddenly and become maximum within seconds could suggest infarction, rupture, perforation, which the differential diagnosis could be myocardial infarction, ruptured AAA, and perforated peptic ulcer. If pain that is gradual and steady come within minutes, it could be inflammatory causes, ischemia and colic. If within hours, inflammatory obstruction, and also mechanical such as ectopic pregnancy and perforating tumor. Next slide. Okay, so for the characteristic of the pain could be colicky or constant pain. So colicky pain is the intermittent pain, then that returns to the baseline of weak pain, meaning that the pain have pain-free period. So colicky pain could suggest that the pain comes from the hollow organ. For the constant pain, the pain that does not come with any pain-free period. So the subtype of the constant pain could be tearing, could suggest AAA, throbbing, could suggest cholecystitis, hepatitis, stabbing, burning, sharp localized, sharp diffuse pain, and also dull aching pain. So next slide. For the radiation, pain could radiate to the back, may suggest that the pain could be due to the AAA, aortic dissection, and pancreatitis. Pain that radiate to the shoulder tip or angle of scapula, which is referred shoulder tip pain, usually due to the diaphragmatic irritation because of the presence of the blood in the peritoneal cavity. So causes could be cholecystitis, liver abscess, saphenous abscess, and also splenic abscess. For the pain that radiate from loin to groin pain, renal colic, and pain that radiate from that radiate to the flank could be pyelonephritis, AAA, and also retroperitoneal hematoma.
Why do you get angle of scapula or shoulder tip pain?
Due to the
Cholecystitis dapat dia. Due to what?
Due to the presence of blood in the peritoneal cavity, so it could lead to diaphragmatic irritation.
Yeah. So, diaphragmatic irritation kenapa dengan dia?
Because they have the same nerve origin.
Innervation effect pain. Embryologically, ini relate to embryo kan. Dia punya distribution, effect pain tu. Sama kan, left side pun sama. Because masa embryology tu, dia punya dermatom, dia punya dermatom tu, yang pertama distribution tu originates around that umbilical or dekat area tu, and but it goes up to the shoulder tip. So usually patient dapat kalau dia panggil bawah sign lah, shoulder tip pain right side biliary colic ke, so it suggests hepatobiliary punya origin lah. So for renal colic kan, how it differ dengan biliary colic and shoulder tip pain tu? Nurul, macam mana beza biliary colic dengan renal colic?
Renal colic
Renal colic tu kawan.
renal colic
How does it differ? Biliary colic tu macam mana, renal colic tu macam mana? You have to tell your friend because it's very important. You can answer this means that you understand. You have been clocking a lot of patients.
kalau renal colic dia true colic, meaning that masa pain free period tu dia hilang. Kalau biliary colic dia tak betul-betul hilang.
Betul. So you tanya patient macam mana kalau patient biliary colic? Who biliary colic, the character dia, and selalunya lah demographic, and how you ask the patient for you to demonstrate that the patient ni fit the biliary colic punya pain graphical representation. Because you said hilang tak hilang kan. How? So you kata colic hilang, biliary colic tak hilang lah. Betul?
Mungkin boleh tanya masa yang hilang, masa weak pain tu, pain score. Kalau betul-betul kosong, renal colic.
So renal colic tu macam mana? Boleh lukis sikit ke? Tunjuk sikit dekat kawan-kawan awak. Graf dia macam mana? Jangan buka Google pula. That's important. Year 5 kan? Kan ada yang lain-lain tahu?
Kalau for the true colic, it is waxing and waning, tapi dia tak pernah reach zero. Kalau biliary colic, dia increase, lepas tu dia plateau for a certain duration, then dia reduce the pain tu.
Betul. That's how you kena tanya kat patient. Exactly macam tu. Yang jawab dia siapa Gambar Arnab je ada.
Syafiqah.
Syafiqah. So bila Nurul cakap renal colic tu reach baseline kosong, maksudnya kalau dalam exam memang dah hantar lah. Dah kena makan lah. So they never reach baseline colic. Biliary colic. True colic lah. Biliary colic dia tak macam renal colic because dia misnormal. Dia reach plateau for long period of time. Dia naik and then reach plateau and then baru dia subside. At least half an hour. At least. Ada orang sampai 2-3 jam. Dia macam kena tumbuk tak lepas. Okay. Okay. Sambung Nurul.
Okay, so next slide. For the exacerbating and elevating factor, for diffuse peritonitis, the pain worsen with movement and relieved by lying still. For intestinal obstruction, the pain could be relieved by the vomiting, and also for acute peritonitis, relieved by leaning forward or curling themselves into ball position. And renal colic, usually the patient is unable to stay still due to the severe pain. So next is the associated symptom. Okay, for acute appendicitis, usually the nausea and vomiting come after the onset of the pain. If the nausea and vomiting before the onset of the pain, it could be gastroenteritis or food poisoning. For the if the patient comes with bilious vomiting, it could indicate that the origin of the pain is distal to the duodenum. If patient came with hematemesis, could suggest due to the peptic ulcer or gastritis. If patient fever or chills, inflammation or infection process, and also for the acute cholangitis, usually patient comes with the Charcot striate, which is right upper quadrant pain, jaundice, and also fever. So next.
Ada dua soalan. Sabar dulu. Bilious vomiting tu you say distal to duodenum, maksudnya dekat jejunum lah.
Distal to the duodenum.
After duodenum, distal to duodenum, after duodenum kan. After duodenum is jejunum lah. You mean there must be something beyond duodenum, kat jejunum baru dapat bilious vomiting. You can agree or to disagree lah. Because you read kan, you kena explain kat kawan-kawan. Boleh ke kalau dekat duodenum tak dapat bilious vomiting? There's something happening in duodenum but still non-bilious. The question is, can you get non-bilious vomiting when the lesion or obstruction still in duodenum? Yes or no je jawapannya, tak payah pergi bayang.
No.
No, okay. So that means if you say no, so you may agree to that a lesion, mainly obstruction lah, a lesion in the jejunum will cause bilious vomiting. Macam tu, maksudnya macam tu lah. Betul? Are you sure?
Yes.
Are you sure? In your exam, if you ask like that, means that you are in a very big trouble kan? So tell me, where does bile come out? In our intestine. Anyone knows?
Is it the ampulla of Vater?
Okay, so
with the obstruction after the ampulla of Vater, then the vomiting will be bilious vomiting.
it must be in small bowel lah. Kalau obstruction after ampulla Vater kat colon, tak keluar itu dah lain lah. Still it must be in small bowel lah. Okay, so ampulla Vater tu kat mana? Exactly.
Dekat
ampulla Vater tu kat mana? Kat duodenum. Okay, kat mana duodenum tu?
Dekat the first part of the duodenum.
Okay, how many part of the duodenum that you have?
Three.
Apa?
3.
Ini bahaya ni.
Oh, 4.
So siapa tahu? Okay, ada 4. So tell me about the length of the ni, Nurul. Length of the duodenum. First part berapa? Second part berapa?
The first part.
Okay, tak apa. You have to read lah. If you get that kind of question in exam, and the question is simple, but you go back to anatomy ke belakang, means that you have to think before you answer kan. you dia akan go back ke belakang. Must be at D2 lah. Posterior part, ampulla of water. Anything distal, still in the small bowel, small intestine, distal to this ampulla of water can have this bilious vomiting. If you have pyloric stenosis or D1, will you get bilious? No, you get projectile. Something like that lah. So second question I was asking, you know Charcot triad. Do you know anything more than Charcot triad? Presenter
For the acute cholecystitis.
Pernah dengar Raynaud Pentate tak? Pernah dengar ke tak? Yes or no je. Tak fikir banyak.
Pernah.
So if your answer pernah, you have to tell what are the two kan. Apa nanti go back baca lah. One of it is about altered mental status. Find another one to complete fast. Okay, sambung. Awak dah beyond your time ni. Kena bagi your kawan pula. Cepat-cepat.
So next is the risk factor for the etiologies of the acute abdomen. Some that has been presented by Al-Hakim for abdominal vascular disease such as AAA or aortic dissection. The risk factor could be elderly, hypertension, peripheral vascular disease, coronary artery disease, previous myocardial infarction, and smoker. For bowel ischemia, advanced age, underlying atherosclerosis, arrhythmia, severe cardiac valvular disease, recent acute myocardial infarction, and intra-abdominal pregnancy. For perforated peptic ulcer, risk factor age between 40 to 80 years old, prolonged use of NSAIDs or steroid, and also history of H. pylori infection. For the ectopic pregnancy risk factor, we need to ask their last normal menstrual period, and also for intestinal obstruction, if they have any other malignancy, any previous multiple surgery, and also hernia. So next is other histories. Slide. Okay, for the drug history, we need to ask whether the patient has any use of NSAID, aspirin, alcohol, substance abuse, past medical surgical history, if they have any chronic disease such as diabetes, hypertension, and coronary artery disease, past surgical history, history of hernia, and history of infection. Gynecology history has asked the patient about their menstruation history, history of history of IUD, previous history of tubal surgery, and also family history, whether they have any family history of this similar presentation, and also history of malignancy. So I want to another presenter.
So next, I will proceed with the physical examination. Next. So for physical examination, we have to look for the general inspection of the body build of the patient, and then we assess the patient of the alert, conscious, if the patient has any pain or in any respiratory distress, and then any obvious scars or pallor or jaundice, and also edema or hernia. And then we also inspect for any objects and equipment at the surrounding, as well as the hand and face examination. We proceed with the abdominal examination from the inspection, palpation, percussion, and auscultation that I'll be explaining later. Next. So next, we can also proceed with the per-rectal examination, and others examination depends on the history. Next. So for the vital sign, we have to check for the temperature. If the temperature is increased, if the patient is febrile, meaning suggestive of infective causes, and check for the blood pressure. If the patient is having low blood pressure, may indicate any hemorrhages. So we may find for source of the bleeding. And then we check for the pulse rate if it is tachycardia, and respiratory rate if the respiratory rate is low, may indicate in a perforated peptic ulcer. Next. For inspection, we may look for an important sign such as distended abdomen at the periphery or center, which may indicate any constipation or any ascites, and then any visible peristalsis that indicate intestinal obstruction, any visible pulsatility such as in a strangulated hernia or an triple A, and then Cullen and Gray Turner sign, which indicate any internal hemorrhage. I'll be explaining later after this. And then any swelling or bruising. If the abdomen does not rise or fall with respiration, may indicate any peritonitis. And then if the abdominal muscle can be seen to be tightly contracted, it may indicate perforated peptic ulcer. Search for any surgical scar or hernia. Next. So for Cullen sign, it is usually the patient complain of sudden onset left flank pain. So it is a superficial bruising in subcutaneous fat around the umbilicus. So it is indicative of internal hemorrhage. While Gray Turner sign is the ecchymosis around the umbilicus and on the left flank, which usually indicate the internal hemorrhage or retroperitoneal hemorrhage that can occur in a severe hemorrhagic pancreatitis or ruptured aneurysm. So these are some of the cutaneous signs on the abdomen. So we also may look for ascites or caput medusa. So ascites is accumulation of the fluid in the space between the lining of the abdomen and abdominal organ. And caput medusa is one of the cardinal features for portal hypertension, which is the appearance of distended and engorged of the superficial epigastric vein. Next. So for the
patah balik belakang. Cullen sign and Gray Turner sign ni dia sign of hemorrhagic lah kan. So which area of abdomen that can lead to these two signs?
Around the umbilicus and the left flank, at the flank
Okay,
pain.
itu kat abdomen lah, itu yang nampak cutaneously. But kalau you go into the surgery, because when you see this, you have to understand which organ kan. Okay, senang cerita, where does pancreas located?
Retroperitoneal.
Yeah, so this is a sign of retroperitoneal. It's not necessarily pancreatitis kan. Anything kat belakang retroperitoneal. But commonly pancreatic lah. Hemorrhagic pancreatitis kan. Hemorrhagic lah. Okay. Ruptured aneurysm of course lah. Kat belakang kan. Retroperitoneal. Ascites tak ada issue lah. Kalau clinically ascites you have to know nak buat apa kalau examination. How many technique to examine ascites?
Two, shifting donors and fluid thrill. We only do the fluid thrill if we see any gross ascites.
Gross ascites. So that's the word yang kena keluar lah, gross ascites. So seraya ni ada banyak ke? How you divide seraya? Okay, seraya ni normal ke tak normal lah orang tanya kan? Betul?
Normal if the patient had undergo pregnancy.
It's abnormal?
Normal if the patient had undergo any pregnancy before. No, normal if.
So how you want to answer? Medical word lah, medical jargon. When a clinical finding, you have to talk about physiological changes or is it pathological changes lah, betul? That's how you tanya. Abnormal tak normal, patient dengar pun macam pelik kan, apa ni, aku ni tak normal ke kan? So basically physiological changes occur in patient postpartum kan. Kadang patient very fat ke apa kan. Mata nampak seraya kan, dia ada white seraya, purple seraya kan. And then pathological would be patient on purple seraya lagi dapat kat siapa?
In liver disease.
Okay, lagi? Cushing semua tu medical knowledge kan? Seraya kan? Important tak? Kan? Because when you see this on a surgical floor kan, so patient ada seraya, you have to think like this lah. Physiological ke pathological? If you suspect pathological, what you need to think? And that's when you need to work out and refer to your colleague appropriately lah. You have to think from the finding. Mungkin ada some ada endocrine issue because bukan semua benda you kena operate je kan. At some time you kena decide lah kan. So clinical feature ni penting lah. It's just not just present. You need to understand. You tengok ni kat mana. What possible pathology that I'm looking. I need to I'm entertaining at the moment. Okay, that's how you should think. Okay.
Okay, Mister.
Proceed. Next slide. Next 2 slide kan. Dah tunjuk kan.
Go back 1 slide, please. Ibrahim, can you go 1 slide before? Alright, thank you. So for next is the palpation. So we do the superficial and deep palpation. So for superficial palpation, we check for the tenderness and any superficial structure. And the deep palpation, we inspect for the internal organ as well as to look for any intra-abdominal mass. So during the superficial palpation, we may look for any localized tenderness at the 9 abdominal region, and then we palpate at the furthest away from the patient, if the patient complain of any pain at the abdominal region, and then look for any guarding, any expansile pulsatile mass, which indicative of aortic aneurysm, any rebound tenderness, which indicative of peritonitis, and then Murphy sign for acute cholecystitis that I will be explaining later, and any Rovsing sign, which is indicative of acute appendicitis, Zachary-Cope sign, and also any palpable abdominal mass during the deep palpation. Next. So during palpation, we may look for the positive Murphy sign, which is an indicative of acute cholecystitis, is where we ask the patient to exhale, and then we place the hand below the costal margin on the right side at the mid-clavicular line, and we ask the patient to inspire. The patient will stop breathing, and the patient will catch a breath. So this is due to the inflamed gallbladder being palpated as it descends during the inspiration. The next we look for Rovsing sign, which is indicative of acute appendicitis, which is when we continuously doing the deep palpation, starting from the left iliac fossa upward. It will cause pain at the right iliac fossa, which indicative of when we push the bowel content towards the ileocecal valve and cause increase in the pressure around the appendix. Next, we proceed with the percussion. So percussion is we do the percussion at the 9 abdominal region to look for any dullness, and we also percuss the liver and spleen to assess the size, the consistency, and also the border of the body organ. And we may proceed with the shifting dullness if we suspect for any ascites, and we only do the fluid thrill if we see the gross ascites. So this percussion is if there is any change in percussion, we may suspect for any underlying organ or any abdominal mass. Last, we may proceed with the auscultation, which is we listen for the bowel sound at the right lower quadrant, generally at the right iliac fossa. So we look for if there is any absence of bowel sound, it may indicative cause the paralytic ileus in peritonitis or any obstruction. If the bowel sound is abnormally active or hyperactive bowel sound, we may suggest any diarrhea, gastroenteritis, or any inflammatory bowel disease. Lazy bowel such as paralytic ileus. And last, we should hear for any presence of bluey, which is the presence of turbulent blood flow caused by any atrial aneurysm or any atherosclerotic related stenosis. So next, we may proceed with the
Saya nak naik lift sekejap. Saya nak naik saya punya wife sampai nak ambil saya kat hospital. Nanti dalam 2 minit kita sambung. Saya dah nak masuk lift lagi. Takut putus.
Okay, Mister.
Okay. Okay, bersambung.
Okay, so I'll proceed with the last step, which is the per-rectal examination. So we do the per-rectal examination to look for any signs of bleeding, and then any tenderness or any masses at the rectosigmoid, and also platters. So for the per-rectal examination, we ask the patient to lie down in the left lateral position with their knees bent up towards the chest, and then we inspect for any lesion at the perianal region, such as skin excoriation, skin tag, or any anal fissure or external hemorrhoid. And then we ask the patient to cough to check for cough impulse, to check for any rectal prolapse or internal hemorrhoid. And lastly, we palpate at the rectal wall 360 degree to assess the anal canal, to check for any rectal lump or any hard stool or any tenderness. So that's all for physical examination.
Kalau ada abscess,
If we during inspection we find the abscess, we may not proceed with the per-rectal examination.
Kalau ada abscess, you boleh rasa per rectal. So what do you find on per rectal examination if there is pelvic abscess or intraperitoneal abscess lah, mainly kat pelvic area, gynae patient kan, tubuh ovarian abscess, refer kat surgery. I think this is surgical cost. Itu biasalah gynae ni cakap contoh kan. Jadi kalau you jadi Houseman surgery, you buat examination yang cakap pas discharge, so you nampak pas discharge keluar kat punggung. Macam mana? Do you feel discharge coming out from per anus? That one could be fistula. What else can you examine per rectal? You said you can check stool. Okay lah, stool tu depend. Kalau you upper giblet, lower giblet, you look for the stool color lah. Okay? If you want to look for malignancy, you feel the around it kan. If you want to suspect in male some prostate disorder, you check prostate. But if in infective abscess, what can per rectal examination tell you kan from your per rectal examination? What are the words that you have to mention to say negative finding ke positive finding?
Fluctuant tenderness upon
Start with
palpation.
B. Start with B, bola, B for bola. It starts with B. Bogginess. Okay.
Okay.
Dengar ke Martin?
Dengar, Mister.
Okay. So among the word yang kena ada lah. Important. Physical examination ni kena lagi tara you explain kat kawan-kawan you kan. As if like you master lah. Dalam seminar ni you master PE kan. So that you tell your friend bit by bit kan. So you cakap Murphy sign, Rothschild sign, SOA sign, obturator sign, BOA sign. These are the thing yang you have to relate balik dengan your colleague just now. Sometimes maybe you tak prepare lah, tapi you should be able to be telling your friend lah. Because these are among the important. Okay. Kalau triple A, you should be telling apa benda lah, acute abdomen tu kan. So you still boleh palpate. Pasal expensive kan. So these are among the thing you need to highlight to interconnect your presentation with your colleague previously lah. Tapi untuk per rectal, that's among the thing. Memang you kena bagi tahu your colleague bogginess. Because sometimes you nak suspect something kan, ada fluid kat dalam port Douglas kan. So you buat PR memang boleh rasa. Kalau tender prostate pun you boleh rasa juga. Macam prostatitis semua kan. Macam tu lah. Tapi kalau you nak rasa internal hemorrhoid, through PR, I think it's wrong. To rasa mass, yes. But to tell it's hemorrhoid, it's wrong. You have to do proctoscopy. Never tell that you know it's hemorrhoid by doing PR. Memang fail. You have to see hemorrhoid kan. Kalau you rasa je macam mass. Mass could be anything kan. Polyp ke apa benda kan. Until you see. Okay.
Okay, Mister. Thank you.
Okay. Proceed
Assalamualaikum. Good morning. Good afternoon. My name is Ahmad Taufik and I will continue with investigations for case of acute abdomen. So in any patient, of course you won't do every investigation under the sun. Your choice of investigations that you want to order should be based on what's the working diagnosis or the provisional diagnosis. So this would be based on the history and physical examination of the patient. So first we go into the blood investigations. Full blood count. If you can look at the hemoglobin in cases of patients with acute blood loss or even chronic blood loss even. And you can also look at the white cell count. Elevated white cell count would be indicative of an inflammatory process. And it can also be due to infection. Infection causes inflammation, of course. And an elevated white cell count or leukocytosis is also a criterion in the Alvarado score for acute appendicitis. So leukocytosis with a left shift or neutrophilia would strongly suggest acute appendicitis. Of course, this would always be based on the history of the patient with migrating right lower quadrant pain. You would suspect an appendicitis. Next, the arterial blood gases. Okay, we can monitor the acid-base status of the patient, and in patients with sepsis or suspected ischemia, you may see uh, the patient is acidotic with elevated lactate. Of course, in cases where the patient may need to go into surgery, then we perform a group cross match or group screen hole, depending on the urgency. Next, please.
You mentioned ABG tadi lactate
Yeah.
kan, high lactate. So what's important of lactate ni? Kalau you any acute abdomen ni, what lactate, high lactate acidosis signifies to you?
It signifies the lack of perfusion, the poor perfusion in the tissue. So,
Acidosis?
acidosis is due to the buildup of lactic acid.
How does it build up? Suddenly lactate high, hypoperfusion, and then suddenly how does it?
Um,
If you have perfusion, what are in the perfusion? What does red blood cell
carries oxygen.
oxygen. So when you have oxygen, so there will be
Aerobic.
perfusion lah kan, aerobic kan. So when you have low perfusion, in the case of hypovolemic shock or septic shock, either one lah, basically the cellular level does not receive, bukan hypoxic lah senang kita does not receive adequate level of perfusion or oxygenation. So hence there will be anaerobic punya activity. So this will produce acidosis, lactic acidosis lah. Okay. Macam dulu, how you run sampai you kejang kan. Sama je, similar concept. Okay.
Okay.
Proceed.
Next, please. Okay. C-reactive protein is a non-specific marker for inflammation. Other than that, serum amylase, if you suspect a pancreatitis, serum amylase, if elevated 3 times higher than the upper limit of normal, then is pretty much suggestive of an acute pancreatitis. Other than that, you should check the blood, urea, and electrolytes for any evidence of dehydration. Patients present with vomiting or diarrhea. The liver enzymes of patients may be deranged in case of biliary disease, for example, or even pancreatitis. And the coagulation profile can also be abnormal, depending on the certain conditions that can cause increased clotting time, such as pancreatitis or any bleeding diatheses. Next, please.
How does LFT depict to obstructive jaundice?
Usually in cases of obstructive jaundice, we have elevation of the ALP, alkaline phosphatase. Uh, alkaline phosphatase. and
And
you
apa lagi?
also can see conjugated hyperbilirubinemia in obstructive jaundice.
Obstructive jaundice. So means that direct is high lah.
Yeah.
What if it's equivocal?
If it's equivocal, uh,
So the jaundice may due to hepatic or pre-hepatic lah.
yeah,
Betul kan?
yes.
Because is it important to know this?
Yes, we want to determine the underlying cause of the pathology. I also read about AST ALT ratio, where you can if AST ALT ratio is more than 2, then it would be highly suggestive of alcoholic liver disease. And if it's less than that, then usually you have hepatocellular damage secondary to infection.
Yeah, betul. Kan right? Now they are study looking into apa choledochor kan, post obstructive jaundice lah, post hepatic jaundice. So sometimes they look at the transaminase level. There's another ratio and then certain reading with a raised ALP to suggest choledocholithiasis. So now they are study looking into it. So far it's favorable lah. So but not yet. For your level mungkin tak perlu lah since you do the reading kan, because transaminitis is very important lah. Like in the past, higher AST level compared to ALT may suggest more of alcoholic lah. We remember last time is easy, AST. ST really one of the commonest liquor causing this is stout. Stout is a type of liquor kan. So AST kan, stout, AST. So you know lah, more AST is higher than ALT, may suggest it's alcoholic punya issue lah. ALT could be many things, could be fatty liver disease, chronic diabetic, uncontrolled for quite some time, so become fatty liver. It's not necessarily be alcoholic kan. Diabetic also can get high ALT and fatty liver lah. But AST is very specific. About ALP, common bile duct issue kan. So some other biliary issue, so some other investigation biochemically that can be performed is GGT lah, serum gamma GGT. It's more sensitive and more specific towards rather than ALP, because ALP can be many things. It varies by age. Youngsters, budak-budak, pediatrics group, usually they have higher ALP. Pregnant lady as well may have high ALP because it's growing bone. So it's quite difficult. They're not really sensitive, not really specific unless you associate to a certain pathology. So that's why they come up with more. But at your level, when you're doing an intern, so what Taufik had mentioned earlier too must be known by heart lah. The according to your lab, when you're gonna work later, you have to know. So because from there you will determine whether this patient is supposed to be admitted under gastro ke, should be admitted on the surgical floor ke, because subsequent treatment tu is important. You don't delay lah. Okay. So coagulation profile, okay, boleh ya. Amylase 3 times higher ni sekarang ni kita diagnose pancreatitis based on what?
Sorry, doctor, can you repeat the question?
Now when we diagnose pancreatitis based on what criteria?
It's called the
Start A,
apa ni?
Atlanta.
Atlanta.
Atlanta cakap apa? Atlanta says it summers in June. Oh, dia cakap 3 benda kan. Basically when you are asked about clinical diagnosis, when you want to answer pun, you bila dalam exam kan, jangan panik. You just when you say clinical, you always think, what is clinical? Clinical must have a focus history, thorough focus examination and investigation yang related. So kalau pancreatitis, focus history and examination dia apa? Epigastric pain lah, relate to the back.
Yeah.
Kan?
Nausea,
Tenderness kat epigastric pain kan. Lepas tu investigation yang related is serum amylase and then imaging yang related lah. So sama juga benda-benda lain lah. Kalau when you were asked, how you know it's clinically breast cancer? Talk about triple assessment kan. Focus history lah, breast lump, minimum age apa-apa, examination, clinical staging tu and mammogram positive of finding. Betul? That's how you answer when people ask you, how do you know kan? How do you know tu, kalau how do you know in a consultant ask kita tu, they talk about clinical lah. Dia bukan talk about, ni kan, talk about clinical. How do you know? How do you know clinically kan? So dia kata, how do you know? Selalu when talk about bedside, you talk about clinical. So you think you need to answer clinically, you go by this. By history, by examination and imaging. So selalunya you akan selamat lah. 80 to 90% you akan selamat. Tapi kena relevant lah, jangan cakap benda tak kena kan. Tak kena, tak sampai lah yang you nak support. Sama juga Tokyo guideline. How do you know this is cholecystitis? How do you know this cholangitis? Tokyo guideline cakap history macam ni, blood macam ni, investigation macam ni. Yang tu dah dikemas, dia terus dia boleh grading dia. Grade 1 to 3 kan. Okay. Dia boleh proceed kan.
Next, please. So next, for the urine test, we can do a urine culture, urine FEMI, and also culture sensitivity if suspected UTI. Blood in the urine can be a sign of infection, trauma, stones, or it can also be a sign of ruptured aneurysm, abdominal aortic aneurysm. Also, pregnancy test should be done in any reproductive age, sexually active woman who presents with acute abdominal pain. ECG,
bukan in any day, in all reproductive. In all. In any sexual activity kadang susah. Kita zaman sekarang ni kan. So to be safe, childbearing age, ambil je. Kalau tanya dia sexually active, kalau kat Malaysia ni dia cakap no, dia tiba mengandung. Tengok-tengok, kita nak ngaku kan. So in all. Okay? And ECG tu salah. Dia ni kriteria I think masa houseman time kot. Now dah 40 years age.
40 years.
Dia dah above 40. Our hospital mungkin 40, nanti ke 40 dah. Because nowadays at younger age you get a lot of disease, so they go lower and lower. But if in by age, if the patient before 40 pun dah ada comorbid, you have to take regardless. So ada basic thing for preoperative assessment, investigation. You kena ada, wajib, compulsory.
Imaging
terus. Blood dulu. Benda yang kau boleh buat dulu lah. Janganlah suruh orang lain buat. ECG satu lah. Kan? Blood apa dia? Kita tengok borang NS tak ni? Masuk buat surgery ni. Borang NS warna apa? Bukan nak patient tak? Borang NS warna apa? Yang lampai patient kat buat surgery?
warna hijau.
Warna hijau. Warna biru kan terkejut lah tu ni. Tapi ada dua lah. Hospital kita hijau lah. Ya? Hospital hijau. Okay. So apa dia minta dalam tu? Tengok saja kali dia kena tengok apa dalam kotak tu. Dia tanya. Dia macam checklist dia sebenarnya tu. Wajib. yang wajib ada. Lepas tu ada bawah tu dia tambahan lah, bergantung pada disease orang tu lah, komorbid orang tu. Wajib ada memang dia siap dah, dia dah printed dah. Basic aja macam tadi lah, full blood count, renal profile, coagulation profile, ECG dengan X-ray, chest X-ray erect. Wajib ada. Kalau patient tu ada ISD, dia want some echo. Kadang dia nak angiogram, koros. Bergantung pada orang tu lah. And then dia akan tengok juga necessity of the patients punya imaging yang related to the disease yang kita tengah nak buat. Contohnya macam kalau thyroid, dia suspect ada very huge thyroid. Because dia nak intubate patient, dia may be looking some for CT imaging, dia nak tengok trachea tu macam mana. Badly deviated ke, jadi slit size ke. So dia nak anticipate difficult intubation. These are the thing yang kita kena as a surgical practice pun, we need to understand this, what the necessity needed. Sebab kalau kita tak prepare awal, we not know about it, jadi delay lah. Walaupun you acute abdomen pun, you tak buat chest x-ray kan. Zaman sekarang, kalau zaman COVID dulu tak buat RTK, macam tu lah. Benda-benda yang tahu semasa tu, kena tahu. Tapi tu among the basic yang you have to know. Okay? For preparing patient for op. Itu GSM or GSH lah. According to MBOS, Malaysian Blood Ordering System. Malaysian Hospital Blood Ordering System. Okay?
Okay. Next, please. Okay. Now we go to imaging. Same thing. You don't order every radiological investigation under the sun. It would be based on what your working diagnosis is. So the first thing that I'm showing here is an erect chest X-ray. This can be done in cases of suspected perforation. It's called an erect chest X-ray because the patient has to be upright. We want, if there is air in the abdominal cavity, then the patient has to be upright because we want the air to rise up to the diaphragm so that we can see free air under the diaphragm, subdiaphragmatic free air. So you can see in this X-ray, you have air under the right hemidiaphragm. We look at the right hemidiaphragm, we don't look at the left because the left can be obscured by gas in the stomach. Okay. Next slide, please.
If you really suspecting patient ada pneumoperitoneum lah, but erect chest X-ray unable to show you lah what you intended to see. So is there any other maneuver that you can do? Let's say you are in Rompin lah, not in UIA kan. So what else in terms of imaging that you could do that could elicit the radiological finding of pneumoperitoneum?
Yeah, we can also do left lateral decubitus chest X-ray. Abdominal X-ray. Abdominal X-ray.
Right, left lateral lah. Okay, so that means right side up lah.
Yeah, right side up.
Okay.
This can also be used in patients who are unable to sit upright. Yeah. Anyway.
Okay. So kalau tak nampak juga?
Kalau tak nampak juga, CT would be.
Kalau peritonitis go in je lah. Kalau tak peritonitis you have time lah. You can do CT scan. Okay. So that's our question we ask lah, the incremental kan. Okay. We proceed next.
Next slide. Okay, this is an abdominal radiograph. You can see a lot of things on an abdominal X-ray, but this is just an example I'm showing of small and also large bowel obstructions. So how do you differentiate between a small and large bowel obstruction based on the X-ray? Because clinically, they would probably present with a similar symptoms, the cardinal symptoms of intestinal obstruction. And on physical exam, they may have absent or hypoactive bowel sounds, abdominal distension, tenderness. So on an X-ray, there's small bowel obstruction. You would have the dilated bowel loops located centrally, such as on the picture on the left. Centrally located dilated bowel loops. And of course, you have the characteristic features of small bowel, which are the valvulae conniventis. And the bowel loops look like a stack of coins. Conversely, in the large bowels, you don't have valvulae. The haustra do not go through the whole diameter of the lumen, so they only go about midway. And the bowel loops are more peripheral than central, more peripherally located. Also, large bowels are, if dilated, then they appear much larger than dilated small bowels. Okay, next, please. Of course, a normal abdominal X-ray does not exclude obstruction. And if you have equivocal findings on the X-ray, then you should also investigate further with the CT, provided that you still suspect an obstruction based on the history and physical. Next is ultrasound. So ultrasound can be used to detect numerous pathologies in the hepatobiliary system, gynae pathologies such as ectopic pregnancy. You can also use it to confirm pregnancy. So you can see abdominal aortic aneurysm, any free gas in the abdominal cavity or fluids. Lots of things, cysts, abscess, masses. So in the picture, this is a ultrasound of the gallbladder showing gallstones in the gallbladder with acoustic shadowing, as you can see. Because the sound, ultrasound, they transmit sound waves. So when there's a stone in the gallbladder, the sound cannot pass through the gallstones. So you have acoustic shadowing behind the gallstones. Okay, next, please. Okay. CT scan is the imaging of choice for most causes of the acute abdomen. You can assess for retroperitoneal injury, and it's usually the first choice of investigation for ureteric colic, abdominal aortic aneurysm, aortic dissection. And you can also use a CT scan to assess for any complications post-operatively, such as any fluid collections or abscess. And you can diagnose necrotizing pancreatitis based on a CT scan. Okay, I think that's all. Next, ada lagi. Oh, ada lagi. Okay. So, if the patient presents with upper GI bleed, for instance, or if the history is suggestive of peptic ulcer, then we can do an OGDS. Similarly, for lower GI bleeds, symptoms of intestinal obstruction, we can do a colonoscopy to find the pathology, to locate, or a flexible sigmoidoscopy for sigmoid pathology, or patients present with rectal bleeding. For
Maksudnya IO terus buat krono. Maksudnya
uh,
masa awak tadi macam tu lah. IO buat krono.
no, not necessarily.
If you acute event, you try basically what are the principle kita bila kita you plan for imaging. Dia macam kita lah nak pergi makan kan. Oh, mesti kedai tu sedap, bersih, murah. Macam tu kan, halal dan thayyiban kan. Macam tu kan, konsep kita nak makan kan. So kalau kita nak buat imaging ni macam mana? Ni nak ajar cara fikir je ni. It must be least invasive first. Betul?
Yeah.
Least invasive. Less invasive as possible lah. Tapi it go by stage lah. If you need to become invasive lah. Kalau dah scope ni semua dah jadi invasive kan. And then you have to be very specific and sensitive lah. Enough. Sometimes you need to do that thing a little bit more invasive, but it offers you better sensitivity and specificity. No point buat benda yang less invasive, tapi sensitivity and specificity is very poor. Buat pun you cannot make decision. No point kan of doing it. Or doing something unrelated completely. And last but not the least is cost effectiveness lah. And because nowadays, even though patient tak bayar, as a pensioner, somebody is paying lah kan. Somebody yang bayar tax semua tu bayar kan. So that's how when you work ke apa benda yang like exam pun you nak jawab pun you jawab macam ni lah. Thinking kan. Thinking process. Kita boleh assess thinking process. Sometimes tak salah pun. Tapi janganlah terus kalau dalam exam IO saya rasa terus saya nak buat CT scan. Buat something yang logical lah. Because CT scan boleh nampak dari terbawah. X-ray pun boleh nampak. So okay kan. Tapi macam you jawab tadi untuk pneumoperitoneum is good lah. Dia macam incremental. Maksudnya you're thinking. Tapi caveat dia, it must not be peritonitis. Peritonitis tak payah fikir. Terus pergi OT je. Okay. Okay.
Next for contrast radiology, these imaging techniques have largely been superseded by CT scan actually, but some cases it can still be useful. Barium enema can be used to find colonic obstruction, such as interception, and emergency IV urogram can be used to assess for ureteric colic, find the location of the stone. Next, please. Oh, Abir. Questions? Okay, thank you. That's all for me.
Okay. Assalamualaikum warahmatullahi wabarakatuh. So my name is Muhammad Razik. So I will continuing the management of acute abdomen. Okay. So the principle of management in acute abdomen is we know that acute abdomen is an emergency. So in any emergency, early resuscitation is very important, and as well as anesthesia. And then we need to find the causes of the acute abdomen, and then definitive treatment. Next. Okay. So in any emergency, in any resuscitation, we need to follow the ABC, which is airway, breathing, and circulation. So we as an houseman, so we need to for example, we as an houseman, we need to consider all this resuscitation, which is the patient airways, the GCS scores, whether less than 8, and then breathing, we give a high flow oxygen, and then for circulation, important to insert the two large bore of granulas for the patients and check pulse and also blood pressures, which is vital signs, because patient is in pain, so we suspect the vital signs would be deteriorate. And then next. So okay, analgesia. So acute abdomen. So of course, patient presented with chief complaint of pain on the abdomen. So in any pain, it is important to control the pain for this patient. So, so in order for us to decide which analgesia we need to give, we want to give to the patients, it depends on the pain score of the patients. And sometimes we also uh, combine two analgesia for this patient, for patients. For example, if patient presented with a pain score of 8 or 9 or even 10, we can give titrated morphine with paracetamol, for example. Okay, next. Okay, next, which finding the causes. So there's a variety of causes of acute abdomen, for example, intestinal obstruction, bowel perforation, peritonitis, and so on. So the most common cause of acute abdomen is intestinal obstruction. So as well as the other presenters has presented, which the uh, the usually in intestinal obstruction, the causes is adhesions. So know that in adhesions, the history of surgical histories is very important for us to rule out. Okay, next. Okay, for the definitive treatments. So in intestinal obstruction, uh, in any patients that presented with intestinal obstruction, we need to keep them nil by mouth, which is we need to rest their bowel, and then fluid and electrolyte replacement is very important because of the cardinal symptoms of intestinal is vomiting. So patients already lost a lot of electrolyte, so we need to give fluid and electrolyte replacements. Usually we give normal saline. And then usually patient presented with abdominal distension, and we can do gastrointestinal drainage via nasogastric tube. And then for the treatment, it depends on the causes of the intestinal obstruction. Okay, next. Okay. So for small bowel obstruction,
Sekejap Tadi letak nasogastric tube kan? What are the principal indication of nasogastric tube yang you tahu? That you know?
principle of
Rest tube indication. In this case, why you insert rest tube obstruction?
to reduce to decompress the
To
the
decompress.
bowel,
Okay, lagi satu. What are the function of rest tube that you know?
to give to give nutritious
To give
for the patient,
nutrition
and
tu
also
tak betul
medication.
To give medication tak betul sebenarnya. What is the most important sebenarnya? You masuk rest tube tu. Prevent aspiration. Lagi?
For gastric lavage.
Lavage. So these are the three things that you have to remember, the principle. So you have to hold to this. Okay? So you remember, and kalau ada any situation that require these three, rest tube is indicated lah. Nutrition tu because principle dia go by enteral or parenteral. Enteral is not necessarily. Kalau the best bagi feeding, not necessarily rest tube, bagi makan je lah. Ke mulut kan. Tapi in somebody yang you need to force, because the answer is not because rest tube nak bagi makan. You choose parenteral. But in a stroke patient, you choose enteral, tapi they can get aspirated. So the key of rest tube is to prevent aspiration rather than giving medication. Okay, that's the principal indication of rest tube. Okay. Kalau soalan bertulis lah, dia tanya kan, that's how you answer. Okay, boleh proceed.
Okay, for the definitive management of small bowel obstruction, so the most common cause of small bowel obstruction is adhesions. So in adhesions, we allow conservative approach up to 72 hours, which we give fluid and electrolyte replacement, nasogastric decompressions, kidney by mouth to the patients. and wait for the symptoms to relieve. If the symptoms does not relieve after 72 hours, then we can consider surgical intervention such as laparotomy with adiolysis or laparoscopic adiolysis. Okay.
Prerequisite before conservative? Prerequisite, mesti wajib kita clarify before conservative.
X-ray, abdominal X-ray.
Itu akan nampak lah, you akan nampak semua bawah feature. Best is you have to exclude ischemic ke tak, feature of ischemia ada ke tak. Kalau no point you tengok selalu that's why kalau kat in UIA the practice is we get the CT scan to see kan, because is there anything that we are dealing with. You may be thinking okay most likely it's action, but if you thinking of something else you have to entertain it. So CT imaging can give you more picture or more information. So you can exclude, you can know where the location is, transition point, is there any other pathology associated, and then you can see juga the bowel variability lah. And then it is already obstructed, dan memang almost contrast pun tak masuk dah, means that about to become like gangrene. No point tunggu 7 days, kena go in now. So that's the prerequisite for 72 hours. But most of the time, patient by 48 to before 72 hours, they will pass motion. After you do all this hydration, decompression, correction of electrolyte, controlling everything back to homeostasis. Okay, that's among the prerequisites that you have to understand before you not allow conservative approach. If you want to read further, but in brief lah, and there is guideline, they call it bologna adhesive IO. Basically small bowel IO lah, bologna management. Dia ada buat table, just nice untuk ni lah, untuk you faham. Okay.
Okay, next slide. Okay, for large bowel obstruction, so mainly the causes of intestinal obstruction in large bowel obstruction can be a tumor, and then the principle is we do resuscitation, we keep them in bowel mouth, and when it depends on the lesions, whether the location of the lesions. So if the lesions is found in the cecum, ascending colon, or hepatic fracture, we can do an emergency right hemicolectomy. So mainly this surgical intervention is to relieve the bowels due to the obstruction. And then next, if the lesions is at the splenic fissure, we can do extended right hemicolectomy. And then if the lesions at the rectosigmoid junction obstruction, we can do immediate resection. And if the lesion is irremovable, for example, the size of the tumor is too big, we can do a proximal stoma. So this the location of stoma is proximal to the tumor. So this is the aim is to relieve the obstruction of the bowel, and then after the symptoms are relieved, then we can go to the next definitive management. Okay, next. Okay, next is causes of bowel perforation. So in cases of bowel perforation, the principle of management is usually an urgent operation to repair or resect the segment of diseased bowel. For example, if we do an chest X-ray and we see air under the diaphragm, which is suggestive of duodenal fatty ulcer perforation or duodenal ulcer perforation, we can do urgent operation and to repair by momentum plug surgery, which you can see from the picture. And if there's a large bowel perforation, we can do Hartmann procedure. So Hartmann procedure is that we resect the we do a laparotomy and we resect the disease segment of the large intestine, and then we do colostomy of the remaining healthy colon.
So what type of colostomy?
Temporary
Temporary lagi?
or permanent also can.
Kau ni nak permanent ke temporary? Tiba-tiba kan nak undur belakang ke? Konsep stoma, soalan stoma tak dapat ini. What is stoma?
Stoma, we bring the healthy part of the colon out of the
Must it always be
of
colon?
No.
So what is stoma? Stoma.
Small bowel also can.
Ni atas ni. Ni soalan you jawab tadi tu. Because basically I was asking you something. Kalau you buat algorithm, you are actually kat bawah. I just nak test you sikit je. Tapi since you don't understand, I need to go all the way up so that you can think balik macam. So year 5 kan, you need to understand. Because Hartman ni simple je. I want to ask you what type of stoma. It must be end colostomy. Hartman temporary or permanent depends on the stage of the disease. If patient habis adjuvant chemo, you can plan for reversal of Hartman. The discussion is the success rate of reversal. Reversing Hartman more difficult than reversing ileostomy. That's the question. Tapi you unable to answer that one because you tak faham konsepnya. So now I ask you, what is stoma? Ask me. What is stoma first?
For diverting the fecal waste out of the body.
Macam I ask you, what is car? The car is macam tu kan. Ada engine, 4 tayar. But when I ask you what is Honda City, you would cakap ada lambang H, Japanese made, macam tu kan. Sama juga, what is stoma first? What is stoma first?
Opening.
Must be opening lah. Okay, stoma must be opening. Okay, tapi apa true definition stoma? It's a hollow viscous connection between two hollow viscous or hollow viscous to cutaneous. Hollow viscous tu banyak benda. What are the hollow viscous that available in the body? Colon lah satu, betul? Small bowel pun boleh, betul? So you got colostomy, ileostomy lagi?
Esophagus.
Apa stomy lagi yang you tahu? Esophagostomy. Ya betul kau buat keluar esophagus. Buat keluar esophagus ni memang kalau jangan kau jawab macam tu terkejut semua orang ni. Apa lagi? Tracheostomy. Boleh ke tak boleh tracheostomy Nazrul?
Sorry tak?
Tracheostomy.
Boleh.
So it's a hollow viscous kan, trachea to the cutaneous. Betul? Kan? So when you understand that, you have to understand that's the stoma is. What is stoma? Kan? So you not necessarily you nak divert feces je. Function of stoma is a lot. Tracheostomy takkan divert feces. It used for
Breathing.
ventilation lah. Jejunostomy feeding?
For
Feeding dah, nama pun dah feeding jejunostomy. Betul? Kalau colostomy dalam Hartman is for diversion lah. Covering ileostomy dalam anterior section, diversion jugalah. Betul? So that's ada function. Ventilation, diversion, feeding, stoma. Ada nephrostomy kan? So sama juga, diversion of urine. Because urine has to go to bladder kencing, tapi when you do nephrostomy, you divert. Kan? That's how you should understand. So bila you talk about stoma ni, you dah faham the indication. Now you decide how you going to create it. You want to do it permanently ke temporarily. Tracheostomy dia boleh jadi selalunya dia akan jadi ni lah temporary kan. Tracheostomy takkan forever orang tracheostomy kan, unless for certain reason lah. NPC kan, tumor unresectable kat atas ni kan, dia tak boleh lah reverse, mati lah patient kan. Sama juga orang yang ada obstruction, unresectable tumor as you said kan, you said irremovable tu dia macam basah-basah dia, you have to use proper medical jargon, unresectable tumor atau lesion. Irremovable ni macam tak medical lah. Okay. So that's why you need to know. So in colon ataupun small bowel, stoma lah, stoma, bowel stoma ni, you have to understand temporary, permanent, and then there could be loop or end or double barrel. Semua benda boleh jadi. Small bowel boleh jadi double barrel. Double barrel means what? Dengan beza dengan loop. Pernah tengok tak?
Pernah.
Tengoklah. Apa yang commonly ada kat ward kita? Common
Double barrel.
Double barrel? Ya ke? Ileostomy lah kan. Banyak patient ni kan emergency je selalunya ni. So these are the thing yang kena tahulah kan. Dalam exam dia akan tanya macam tu lah. Stoma ni apa, end ke tidak, double lumen ke tidak kan, double barrel ke tak, loop ke tidak. So is colon ke, small bowel ke, tadi ileostomy lah, ileum. Why you tak buat jejunostomy? Kalau macam ni post anterior section buat jejunostomy senang. Kenapa nak buat ileostomy? Apa concern sangat kita ni nak buat stoma ni pun kena pilih betul-betul. Macam you tadi nak buat esophagostomy kan, you cakap tadi kan esophagus kan, so semua orang terkejut kan, kalau kejut dengan exam matilah kan. Tapi why tak boleh buat kat esophagus? Kenapa kena buat dekat kan? You have to answer me why.
To allow the absorption
lah. So kalau absorption does not occur, what happen?
patient will be under nutrition.
So what are the condition that we calling that with a stoma yang patient tak ada boleh absorb ni? Condition apa tu? Hypostoma tu kalau keluar banyak. Kalau tak keluar, dia jadi shock bowel lah. Nak dengar tak ni? Year 5 kena sampai level 2 lah discussion kan. Kena sampai tu dek. Okay, saya tanya you kan, kita jawab lah. Mental plug duodenal ni kita panggil Graham patch kan. Okay, mental plug tu Graham patch. Large bowel perforation, Hartmann procedure. Commonly done. Hartmann procedure ni apa? What type of procedure?
We remove the disease part of the colon.
Okay, selalunya kat area sigmoid lah. Disease part, so?
And then when we remove the remaining part of the proximal remaining part, we do colostomy.
And colostomy. Jawab tu, practice macam tu dek.
And colostomy.
And then distal part?
And then the distal part will be close and left inside the abdomen.
As
a stump.
As a stump. Jawab macam tu. Year 5 kena able to answer perfectly. Basic ni dikira basic ni jadi houseman. Hartmann, kena faham. Hartmann ni an emergency procedure. Dia tak fikir dah nak cantum apa, patient tak stabil kan. Buatnya Hartmann. Commonest is perforated diverticulitis. Very rarely dekat tumor lah. Saya commonly perforated diverticulitis. Tapi anyhow, anything left-sided tu, you boleh buat Hartmann, you buat lah. Because the aim is to remove the lesion appropriately, buat distal stump and proximal end colostomy. Reversal rate dia success rate about 50% je kot. Tak tinggi lah. So that's why Hakman ni kalau tanya colorectal surgeon dia jarang nak buat. Sebab dia fikir nak reduce, nak reverse tu payah sikit. Siang patient tak boleh kena ada stoma forever. Tapi colostomy is better than ileostomy because why? Who patient with colostomy has short bowel syndrome? Pening dah ni Nazrin. Kita go back one step question behind. Apa colon buat? Apa small bowel buat?
Colon reabsorption of water.
Water saja kan? So yang keluar jadi hampas najis je lah. Betul tak? Because why? All the nutrient has been absorbed before entering large bowel. Kan? So colostomy tu okey lagi lah. Kan? Daripada ileostomy. Patient yang akan banyak isu sangat ni, banyak isu sangat dengan electrolyte lah, apa benda, dehydration, kau-kau ni ialah small bowel punya stoma. Large bowel punya stoma, yang kita risau selalunya dia punya ni ialah prolapse. Thrombus colostomy dan sebagainya lah. Okay. Okay, last question lah. Saya tanya banyak sangat kan. Ada banyak lagi ke slide awak?
Inilah.
Okay, last. Okay. As a year 5, going to become houseman for the next 2 years of your life. It's a quite fun and miserable life. How many type of colectomy that you know, that you really need to know as a year 5 nak masuk ni? Kalau tak tahu ni macam yang pergi exam nanti orang discuss pun kau pun bela. Colectomy. You ada right hemicollect lagi?
Right hemicollect, left hemicolectomy.
Okay.
And then we have anterior resection.
Anterior resection. APR.
And then we have APR.
Last sekali.
And then we have panproctocolectomy.
Panprocto tu detail sangat, boleh lah. Hakman lah yang kena tahu sangat. So you mention panprocto, what the indication of panprocto?
In patients with familial
adenopathy lagi,
and also ulcerative colitis.
Ulcerative IBD lah. IBD mostly is UC. You tak apply kat Crohn sebab awak ni bagus ni dia. Kenapa UC kita boleh buat panprocto, IBD Crohn kita relax sikit kan?
Because UC involve all parts of the colon.
So Crohn?
So the Crohn's is only.
Crohn ni dia whole alimentary tract kan. Kalau kau dah bantai habis semua kolon buang, lepas ni kau nak buang semua bawah, matilah patient tu. So kita tend to do apa yang perlu je dalam Crohn. UC ni kalau you dah tahu, you akan prevent dia. You buang your panprocto siap-siap, you buat end ileostomy kan. Lepas tu you akan prevent patient dapat komplikasi lah, toxic megacolon, colorectal CA kan. Just treat all the autoimmune tu untuk prevent dapat cancer dekat ni lah, PBC, PSG kan, PSC kan. Baca lah medical book, dia kena interrelated dia. And then baru dapat lah panprocto. Okay. Korang tak buat sebab kita akan research, sebab dia continuous kan. Buang banyak-banyak tu nanti semua bawah kena pula. Lepas tu Crohn dia macam-macam manifestation. Kalau nak bawa sangat patient dalam clinical, patient Crohn dia bawa banyak sikit finding untuk undergrad lah. Kalau untuk master, UC pun dia bawa, Crohn pun dia bawa. Okay, perianal fistula, sometimes patient boleh dapat memang primary perianal fistula, FIA, fistula inano, or secondary causes. Commonest causes, IBD lah. Second is infection lah. Apa nama infection, IBD dengan malignancy lah. Okay. Okay, banyaklah soalan kat Nazrin ni. Belajar tak? Sampai level tu kena baca. Okay, Abdominal. Tapi the most important dalam definitive treatment ni, kalau dalam acute abdomen ni boleh jadi dalam trauma je lah kan, rupture sana, rupture sini kan. So you always kena go by ATLS guideline lah. Primary survey, secondary survey, you kena divide macam tu. Emergency ni trauma ke non-trauma? Kalau emergency ni dia trauma ke non-trauma? Kalau you cakap tadi ada rupture tu, rupture ni semua jadi trauma kan, semua jadi acute abdomen kan. So your management tu research dah betul, dia kena follow ni, dia trauma punya ke non-trauma. Kalau trauma ATLS, kalau non-trauma follow lah apa yang patut. Okay? Okay, dah sambung belas.
Assalamualaikum warahmatullahi. So moving on to the peritonitis. So Nazria has already talked about resuscitation and pain management. So peritonitis can be localized and generalized. So in localized, we mainly suspected for patient may have appendicitis. So normally it depends on the diagnosis. If patient come with the peritonitis. So in the diagnosis, we made is appendicitis. So appendicectomy should be initiated. And for acute diverticulitis and self-ingitis, we give antibiotics. However, in generalized, where we didn't know any the causes of peritonitis, so we give a broad spectrum antibiotics. It's a empirical broad spectrum antibiotics. For example, cephalosporin and metronidazole. So if we cannot diagnose anything, then urgent laparotomy is indicated.
Cannot do anything tu maksudnya cannot bagi antibiotik pun.
I mean, if we cannot determine the source of peritonitis, the causes of peritonitis, so urgent laparotomy is indicated. Next,
urgent laparotomy, okay. Exploratory laparotomy. Laparotomy ni is entering abdomen. Gynae dia buat fan and steel tu pun dia cakap laparotomy sebab dia masuk lah. Tapi dia nak tengok liver tak nampak pun, kena gagau tu. The best is midline lah. Midline exploratory laparotomy. My question to you before you move to the next. You say empirically you give broad spectrum antibiotic, cephalosporin, metronidazole. What's your aim? Kenapa tak pakai Unasin ke, murah sikit? Answer as a year 5 going to become a houseman. Jangan cakap embo saya suruh. Nanti saya akan tanya pula. Agak-agaknya aim your embo tu apa?
To cover both aerobic and anaerobic bacteria.
Anaerobic. Okay. So anaerobic apa dia? Itulah choice anaerobic yang mana satu? To cover both ada dua, mana satu? Dia dah dapat posting surgery tahun 3 sampai tahun 5 ni, 2 tahun dah ni. Auto pun menggunakan prinsip yang sama. 3 tahun ni. Jadi houseman lah. Bila ni, MO kat KKM ni, dia tak ajar lah. Kalau kau tak ingat ubat ni, lagilah kan. Melayang file ni lah. Kenapa? Why? Tak tanya masa ikut round. Kenapa? You dah jawab nak ada idea tapi you tak commit. Jadi doktor ni kena commit. Doktor ni dia commit je. Commit correct ni lah kan. Commit tak correct tu kamikaze apa ni. You dah jawab dah tadi. Kenapa boleh cakap saya metronidazole? Dia nak jawab tapi dia macam senyap kan.
I'm not
Dia nak
sure.
cover, cephalosporin dia nak cover gram positive mostly. And then third and fourth generation ni, they have coverage juga for some gram negative, of which second and first generation of cephalosporin does not have. So third and fourth ni dia boleh cover gram positive mainly and important gram negative. However, metronidazole cover for anaerobic. That's why lah you tengok selama 3 tahun ni, kalau you tengok lah, mana-mana work pun pakai benda yang sama. So that is principle behind it. This is what you need to know. Mungkin masa you kerja nanti 10 tahun lagi, cephalosporin hilang tutup, terbakar ke tahun depan kan, tutup. Bukanlah generasi lain. Ataupun dapat resisten yang kita tak tahu. Macam COVID nanti tiba hidup happy-happy kena pakai mask 3 tahun dalam rumah 3 tahun. Sama juga bila dengan antibiotik ni. Tapi prinsipal dia whole. Kau kena cover gram positif, gram negatif dengan ni. Tak kisahlah antibiotik apa akan berlaku dalam masa 15-20 tahun. Bukan kena cover 3 benda ni. Boleh?
Okay.
Proceed dia.
The next slide, please. So next is abdominal aortic aneurysm is one of the acute abdomen in this seminar. So for the operation, if the patient, so abdominal aortic aneurysm can be asymptomatic, symptomatic, or rupture. So for an asymptomatic, if aneurysm is more than 5 centimeter or 6 centimeter is already critical. So we do operation or surgically corrected by graft, or which can be by 2 types, open aneurysm repair or endovascular repair. Because even patient is asymptomatic, the risk of rupture, the dilation of the aneurysm itself can increase to 2 centimeter in a year. So for symptomatic aneurysm at any size,
Increase to apa? Increase of rupture is increase to 2, tak faham.
2 centimeter every year.
Apa yang 2 cm tak faham? Maksudnya?
The size of aneurysm.
Maksudnya every year dia naik 2 cm. Maksud awak macam tu? Do you mean that?
Yeah.
No. Dia boleh naik berapa cm dia nak naik pun setahun. 1 cm boleh, 0.5 cm boleh. How are you going to explain asymptomatic? Dia simple tapi always because you tulis more than 5 operate, more than 6 is critical. So what does it mean? Not necessarily more than 5, it depends on gender. In female is 5 lah. Lelaki angkat tangan. Dia baca tak ni? Asymptomatic. Ni baru single triple A je ni. Dia tak campur dengan datang kanser ke, datang apa benda ni. Okay, aneurysm ni, what is aneurysm in the first place?
Aneurysm is dilatation of aorta, abdominal aorta.
The aorta, of any lah, all the viscous tu lah, vessel tu lah, aorta tu. By how many percent? Dia boleh dilate tapi kalau measure kau punya aorta, kalau normal kita 2.5, mungkin kau punya 2.7. So kau pun aneurysm lah. Then you call it a proper aneurysm.
By 50% of the normal aorta size.
50%. So aneurysm ada true dengan pseudo lah. Betul?
Yes.
Betul lah. Okay. Sama macam diverticulum concept. Layers kan, dia go by layers kan. So now you dah understand a bit of what is aneurysm, what are the possible layer yang kena. So in this asymptomatic aneurysm we're talking about triple A ni must be a true one lah. Kan? So isu dia bila dia ada layer-layer ni dia akan dapat thrombus and then risk of rupture is high. You do surgery in 5 and above in female and more than 5.5 in male in asymptomatic patient because the risk of rupture is higher by that size. Okay? So usually dah about 7 to 8% because surgery punya risk either one lah, you nak buat open ke endovascular is about 5% je mortality risk, mati lah 5%. Okay? Tapi rupture is about 7-8% lah. You tak buat apa-apa, rupture lagi tinggi mati. So what that's what to offer surgery. If you go lower than that, of that size, there is a study lah they say, if you go size in asymptomatic patient lower than the size mentioned just now, asymptomatic dia punya risk or of rupture tu is lower than risk of surgery 5%. Mungkin 3% je. Maksudnya kalau pecah pun 3 orang je mati. 1 orang kan. Saiz kurang pada 5, you operate 100 orang, 3 orang je rupture. Tapi kalau ikut statistik rate of mortality, 5 orang pass away. So macam doing surgery is more harmful lah. So tapi bila you buat rate of rupture is higher than rate of mortality at intervention, that's why kita offer kat patient. Okay, understand? Okay, asymptomatic tak cerita lah of any size. What kind of symptom you're talking about?
Symptoms that we may think of is abdominal pain, abdominal back or flank pain, any thromboembolism.
Yes, good.
And then they cannot be attributed to any other causes.
Yes. So causes dia due to the thrombus. Kalau thromboembolism itu due to the thrombus in the aneurysmal part. Yeah. So what happened in the aneurysm tu sebenarnya sampai boleh ada thrombus? Zuhur dah. Awak last kan?
Last.
Okay, last. Okay. Sebab flow dalam arteri apa? Flow dalam vessel ke arteri? Dalam vessel ialah apa nama flow tu? Free flow. Cuma kanan lah. Lamina flow.
Lamina flow.
So kalau ada aneurysm tak cantik ni dia panggil?
Turbulence flow.
Turbulence flow. So turbulence flow senang ada?
Senang ada.
Next question saya nak tanya apa? Pathology. Pathology ni. You get asked that kind of question dalam discussion tu, you dah tahu. Aku dah tahu dah nak jawab soalan apa nak keluar. Sebelum examiner buka mulut aku dah ready dah jawapan. Dia tanya tak tanya je. Focus triad. Okay. Macam tu exam dalam exam kan dia macam tu dia. Kalau dekat dia triple A, I myself examiner, okay aku dah tahu dah aku nak test apa pula ni. So you as a candidate, kalau aku cakap macam ni aku boleh prepare dah jawapan apa examiner possible dia tanya. Sebab you tak boleh baca examiner punya mind kan, tapi you tahulah apa scope of discussion yang kena tahu lah. Dan tadi kita test on complication in symptomatic you can answer. So means you have passed one hurdle. So I'm asking you more lah. Tapi you okay lah sikit-sikit je. Tapi macam tu lah. It's good. You think. Because kita nak tengok you thinking je. UBS ni dia nak tengok when you are put under pressure, can you think on your feet? Dia macam senario on call semuanya macam tu. Kita bagi senario yang memang kau tak boleh nak call orang. Kau kena decide. Unless orang tu apa, tapi tak adalah sebenarnya sampai kau tak boleh contact orang. Tapi kita saja ni nak tahu kan. Jangan jawab I ask my MO, I call my consultant, memang takkan membantu kau. Dia akan mengeruhkan keadaan. Dia akan tanya, apa consultant kau cakap dengan kau nanti? Kau kena jawab juga soalan tu. Dia tak boleh. Inform my seniors just to show that you are safe. But you don't answer question. Macam tu lah. Kita dalam hati, kita kata okay, budak ni okay, safe. Tapi tak ada markah kosong ni. Okay, jangan anggap I inform my senior tu, okay aku dah lulus. Tak. Kita je rasa you lulus, tapi markah kosong je. Sebab tak ada jawapan. Dan tu kau jawab lah semua dalam exam, I inform my senior je. Jadi staff nurse lah. Inform doktor je semua kan. Okay. Tapi tak apa. You have to understand tu je. So basically ada berkos triad. So kena baca lah. And then that's how dapat complication lah. Shower emboli. Sudah dengar shower emboli tu, bacalah emboli tu apa. Dengar thrombus, bacalah thrombus. Fate of thrombus. Baca sikit basic-basic tu. So that you can understand. But if you understand a bit of pathology ni, when you read the management, it will help you a lot. Okay? You understand. Okay. Ada lagi? Boleh proceed.
There's major hemorrhagic, major GI.
Cepat.
Next, Ibrahim.
Jadi tak payah lagi banyak sangat lagi.
Next.
Baca je tengok je.
Next.
Pun tak apa. Okay, complication yang penting kalau buat EVA, endovascular aneurysmal repair, EVA, complication yang penting. Satu keyword ni kau jawab, maksudnya aku tahu kau baca lah. Kos mahal. Kos naikkan gaji bila dah beli. Murahkan harga barang tu. Jangan jual harga Yahudi. Bila dah beli.
Is it recurrence rate?
Recurrence rate. No. Kalau buat EVA. EVA is minimally invasive lah kan. So what are the complication ataupun benda yang kita kena concern kalau kita buat EVA ni? Every year kena follow up. Tengok apa kan?
I'm not sure that.
Kita kena nak tengok endolin. Okay. Tak apa. Nanti you go through balik, you baca balik.
So for acute bowel ischemia, need urgent laparotomy if intestinal ischemia is suspected. So other choices could be embolectomy, resection and massive resection, and small bowel transplantation. We can do in arterial or venous infarction. So next. Major gastrointestinal hemorrhage. As we mentioned earlier, resuscitation is very important.
Ada soalan kan? Aiman?
Yes.
Kalau kita tadi dulu detail sangat lah. Tapi kalau dalam bowel section ni, soalan dia kena tengok lagi je. Kalau as doctor simple principle kan, anything yang gangrene selalu dia dah ischemia ada gangrene, irreversible kan. So you have to reset. The question you nak anastomose ke you nak stoma kan dia. Misalnya in ischemia by practice kita akan stoma kan keadaan. But knowing the understanding and soalan Nazrul tadi tu, whether it's short bowel ke tak short bowel depends lah. That's why you need to know what you resected. Kan? Kalau you reset colon tak apalah. You just stoma kan terus, double barrel. It cannot become loop because you dah potong kan. You dah potong, so you become double barrel. But if it's small bowel, you have to understand. If you bawa, bring atas, could it be very short bowel? If you have to, you have to. Tapi you know, patient will get short bowel. Dipanggil intestinal failure, type 3. Okay, intestinal failure. So, plan your management nanti dia lain lah, dia kena bagi TPN dan sebagainya. So, the principle dalam always bawa ischemia ni resection. But never, kita principle ajar jangan anastomose lah. Kalau ada ischemia, bawa jadi stoma. Tapi you have to understand, kena ada sikit at the back of your mind, where is the resected area. Kalau very high in small bowel area kat jejunal semua, high output stoma, short bowel syndrome. Dia tak function lah, tak ada absorption kata Nazrul tadi kan. Okay. So, yang transplant tu is not your level lah. Your level is resect stoma je. Tapi kalau dia nak test you sikit, jangan tanya tadi lah, kalau atas sikit, short bowel. Itu je, soalan dia pusing-pusing sama je. So short bowel macam mana? Sama ada kita ni lah, kita reverse balik cepat-cepat lah biar dia jadi tak short. Cubanya could be okay, tapi kalau you anastomose pun ischemia, there is chance of anastomotic leak. Ischemia tak pasti kan. So itu antara discussion lah, kalau you boleh jawab elok-elok, itu dia akan tanya. Secara general je. Dia takkan tanya nak transplant ke apa kan. Master pun tak tanya sampai level tu lah. Dia tanya basic-basic dulu. Dia akan tanya origin ataupun causation of the ischemia. Could be arterial or venous. Arterial selalunya dia ekstensif, hitam semua. Kalau venous dia selalu patchy-patchy sikit. Okay? So why? Kalau apa nama arterial, thrombotic or embolic lah. Kalau venous selalunya dia congestion, dia compress or dia impede the flow of the artery. To impede the flow of the artery means arterial supply is not good to the area that is supposed to be supplied, become mula dia jadi inilah hypoxic and then become ischemic. Ischemic dia jadi ini dapat gangrene. That's how you need to answer. So I asked the question earlier on the first slide tu. So kita nak carry semua sampai di sini. Prinsip yang sama je. Okay. Nah masuk GI. Ke apa ni kan.
So major gastrointestinal hemorrhage, most of the case we need to transfuse inactive bleeding, and when there is hemoglobin less than 7. So we can consider, we have to consider in high risk patient where we give high dose proton pump inhibitor, for example, esomeprazole in 72 hours. And then we do endoscopy in stabilized patient on in first 12 hours of bleeding. So next. In high risk patient, these are the things that you have to take into account where patient more than 60 years old, present of shock, the systolic blood pressure less than 100, hemoglobin less than 10, and any severe intercurrent disease, for example, liver disease, variceal hemorrhage. So if present any of these following, so we admit in high dependency ward. We restore circulating volume, and then consider central venous pressure, monitoring central venous pressure, and then we give we observe for any continuous bleeding. So we do endoscopic treatment, for example, injection of the bleeding vessel, and we can consider observe as above if endoscopic treatment is not needed. So in patient, after we give resuscitation and transfusion, when patient is still hemodynamically unstable, so we consider doing upper endoscopy to rule out any upper GI causes.
In GI bleed, what type of shock you expect?
Hypovolemic.
So how many class of hypovolemic shock?
At 4 class.
Okay, nanti baca lah what are the, because among the question you're gonna ask lah. Okay, so you cakap endoscopic treatment lah, or surgical treatment lah. Okay, just nak tanya lah, when you do endoscopy, you nampak ada ulceration. How you classify the ulceration? Based on what?
Based on the forest.
Forest classification ada berapa? Inilah soalan exam kan. Bukan dia, benda orang pergi masuk scope room dia tahu benda-benda ni kan. Baca note, baca report kan.
To remember.
Team B ni misal Azrin scope, misal ni scope, these are the thing dia akan tengok. So ada berapa kena baca lah. Okay. So kalau kata fail treatment, nak buat pergi surgery, so nak buat apa? Buang perut. Ni pun another thing kena tahu kan. Ada ulcer kan? Ulcer apa yang concern sangat sampai ulcer tu dapat apa jadi tak faham ulcer. Faham tak? Ulcer tiba ada bleed. Cuma kenapa Pernah tanya tak Aiman? Atau siapa kawan lain dia tahu jawapan ni?
Is it result bleeding ulcer?
Bleeding ulcer lah. Bleeding ulcer. Ulcer semua ulcer bleeding kan? Kau dapat mahu ulcer bleeding kan? Sampai masuk hospital kan? Tak ada kan? Minum air masak je kan? Kau mak cakap, minum air masak banyak Aiman, musim panas ni. Tu je kan? Tak ada masuk hospital pun. Tapi kenapa dalam stomach tu dia sampai macam-macam kan? Masuk ICU bagai kan? Tu dia cakap masuk ICU tu. Inform consultant ni. Kenapa ulcer bleeding. First, what is ulcer? Okay. Exam kalau kena undur belakang ni, kena jawab, wajib jawab. Tak jawab, kalau berenang ni, tadi kepala keluar tarik ni sekarang hidung ni. Hidungkan hidung. Kena naik balik. Ulcer is a break
out of mucous membrane.
Macam mucosa lah kan.
Because, yeah.
So, why dia break in mucosa, tiba dia bleeding? Apa yang sampai dia break, sampai ada bleeding?
Tak boleh.
So basically inflammation lah. So dia break in mucosa. So that area tu selalunya dia ada vessel. Stomach kan rich in blood supply. Dia banyak lah vessel-vessel yang tertentu. Commonly dia dekat branch of what?
Superior mesenteric.
Mesenteric. Kau bleeding tu bau iskemia. Kau mati stomach kau. Tak ada semua bawel, jawapan mati lah patient. Bukan shock bowel lah, no bowel. Dia bleeding dekat posterior gastroduodenal artery. So that's why bila you dah buat endoscopic treatment, fail you go surgery, you nak pergi tackle artery tu lah, you nak buat apa dengan artery tu? Tahu tak tahu surgical management of ulcer ni, bleeding ulcer? Buat underrunning. Underrunning basically you tie dia punya vessel tu. Tengah bleeding tu. You risau tak nak tie bleeding ni? Tai kan mati lah perut tu.
Tak, sebab
apa? Sebab kita tie sikit je. Sebab apa? Jawab dah tadi.
it has multiple branches.
Dia banyaklah blood supply lah. So kita boleh buat. Component get eroded is the posterior branch of gastroduodenal artery yang selalu bleeding tu, ulcer tu. Okay. Kalau dia bleeding kat tempat pelik-pelik ni selalunya associated dengan tumor, malignant tumor. Malignant dia encroach kan, dia makan. Encroachment of tumor growth kena hyperacidity, semua ni is a type of inflammation. Betul kan? Betul lah, baca buku batul tu kan? Ada 9 type of inflammation kan? Kalau kau nak ingat lah yang mana for the next of your career life, flip sikit apa yang saya cakap ni. Nanti you can understand banyak benda lagi. Bukan sekadar ulcer je. Beyond ulcer you can understand. Okay. So you underrunning. So dapatlah benda ni. Okay. Kalau teruk juga tak boleh hilang tak? Zaman dulu orang selalu buat. Pronasi dulu buat. Zaman kita orang tak buat lah. Dah dengar distal gastrectomy tak? Dalam buku. Kau tak baca? Tak baca ni. Underrunning tak tahu ni. So that's how you need to understand prinsipal untuk year 5 sampai level tu. Endoscopy. Pokok dia tanya lah what is ulcer semua, forest classification. Kalau forest tu pun rasanya kalau dalam 100 orang tu, kalau saya tak baca buku, 100 orang tu 50 dah syahid lah. Tanya forest tu dah syahid dah 50 orang. Okay, lepas tu the fittest lah yang akan boleh jawab ni. Distinction dia akan boleh jawab lah. Distinction akan jawab distal gastric lah. Super distinction dia akan jawab apa? Macam superhero ni level. Because of PPI distal gastric dia tak buat. Itu memang ultimate. So you baca lah dalam buku kenapa. Okay, proceed.
So this is just the difference is low risk. None of these risk. Patient didn't have any of this risk, so we just admit to general ward and allow fluid by mouth, and then observe for any continuous bleeding, and arrange for endoscopy on next elective list. So it is not urgent for us to do endoscopy. And then I think
Saya ni tak berapa tepat lah adik. When you say G-ablit, you have to define upper and lower. Upper and lower. So apa beza upper and lower? Bleed. Lukman. Lukman. Aiman.
it's anatomically it's bleeding above the ligament proximal to distal of triads.
Ligament of proximal to ligament of triad is upper G-ablit, distal to it is lower G-ablit. So what are the feature of upper G-ablit dengan lower G-ablit differ ni? Yang dengan lower G-ablit, oh okay. Upper G-ablit, no.
So lower GI bleed patient may present with fresh bright red.
Itu presentation.
Mhm.
Kalau natural history ni, history tu maksudnya apa yang boleh berlaku macam cancer lah. Natural history of cancer. Cancer dia start dengan ni, dan sekali dia pergi metastasis. Macam tu. So kalau natural history of lower G-ablit ni, apa natural history of lower G-ablit differ dengan upper G-ablit? Okay, tak apa, kita cepatkan. Lower G-ablit dia akan apa orang kata, dia boleh resolve by itself in 70% at most by itself. Okay. Upper G-ablit saya memang kena scope lah. Dia memang always surgical emergency. Whether you scope now or within 24 hours. And depending on situation, tak ada masalah. Tapi kena scope. Okay, kena scope. Lower G-ablit dia boleh stop within 70 hours, dia akan stop in 70%. Lagi 20% tu dia takkan stop lah. You kena buat sesuatu. And then about 10%, lower G-ablit ni causation dia datang daripada atas juga. Proximal to ligament of triad. So kalau you suspect yang 10% tu, you kena buat ODDS juga lah. Boleh buat bawah saja. Commonest lower G-ablit is diverticular bleed. Commonest lah. Lepas yang lain benign causes such as hemorrhoid. Polyp pun boleh jadi benign malignant lah. Itu benar-benar angiodysplasia in a CKD patient. Ini benar-benar yang kena tahu. Upper G-ablit, forest ulceration most of the time. Sometimes tumor, sometimes polyp dan sebagainya, angiodysplasia, Galofoy disease dan sebagainya. Okay. Galofoy Okay. Galofoy. Baca. Penuh markah upper G-ablit ni kena baca yang sebut-sebut tadi. Okay. That's how you divide. Macam ni macam tak bagus dia. Aku rasa salah ni kalau macam tak syok, macam tak bagus lah semester. Okay. Lagi?
So, just a little bit about endoscopy next. So
tapi kalau 5 minit boleh tak, saya ada benda nak kena buat.
So in upper GI, we have to determine the site and probably any esophageal varices. So it is urgent within 12 hours of GI in high-risk patient and hemodynamically unstable. And then endoscopic features that put patient on high risk, which are all these things: active spurting from artery, visible elevated vessel, and gastroesophageal varices. Is the urgent surgical intervention for gastrointestinal. Next. So it is urgent in clinically or endoscopically high risk who suffer one rebleeding or any two rebleeding or any massive bleeding which not improve with any resuscitation. All from for the
Not improve by ke my resuscitation?
No, improve by resuscitation.
Macam kau ngaku je macam tak boleh nak resuscitation je. Okay. Tak faham in the iris who suffer one rebleed, suffer two rebleed. Tak faham. Saya tak faham. Apa maksud suffer one rebleed, suffer two rebleed? Ni apa ke lower apa lah kot ni?
In patient with the patient in which is high risk patient and who suffer rebleeding, we need urgent surgical intervention. But those who are not in high risk patient but suffer two rebleeding, so we do
terus pergi OT potong je. Terus. Kita selalu buat dekat ni, dekat UIA ada je patient. Boleh rescope. Kalau atas lah apa ceblik. Kalau boleh rescope. Tak boleh rescope, kita tengok. Patient stable tak untuk buat angioembolize. Kita stopkan salur darah yang bleeding tu. Dr. Prof Razali akan buatkan. Fail juga baru masuk OT. Under running dan diastole which is under running je. Tu kalau upper GI. Kalau lower GI, similarly masuk OT buat apa? Kalau atas CTA still bleeding, reset the area lah. Right sided, right hemi, limited right hemi lah. Sebab dia bukan cancer kan, dia bleeding ulcer kan. For some certain reason lah, diverticular ke apa kan. Kalau lower je boleh, diverticulum lah. So kalau dia left sided sigmoid tu, buatlah sigmoid colectomy. Nampak idea dia? Faham?
Okay.
Sebab saya tak faham tapi itu prinsipal, dapat idea kan. Tengok apa GI kalau lepas tu kena bagi apa yang lower. Kalau campur ni kau pun pening, kawan kau yang tak buat presentation ni lagi pening kot. Okay dah, next je. Jangan baca lagi pening, aku tengok pun pening. Tak boleh nak faham. Habis dah. Okay. All in all okay lah kan. So every presenter was asked about at least 3 questions lah. At least lah. Some boleh jawab, some tak boleh jawab langsung. So